This is Uzma Amir Jilani. Today I will show you how to interpret a chest X-ray. In this video lecture, you will learn about the normal anatomical landmarks visible on a chest X-ray and interpretation of some common abnormal findings that helps in diagnosing a case. Remember one thing, that while making a diagnosis, we have to keep in mind the medical history, clinical signs and symptoms, and match them with the X-ray findings. We cannot diagnose a case on the basis of chest X-ray alone. In this X-ray, which shows the normal anatomical landmarks, you can see many things are visible on a chest X-ray. This is a posterior anterior view, and you can see the bones, the lung fields, the heart shadow, and the domes of the diaphragms. To remember that the things which are visible on the chest X-ray, there is a mnemonic which is comprising of alphabets from A to H. You can see the airway and apices of the lungs, bones, that is the rib cage and the clavicle, the sternum, cardiac shadow, diaphragm, edges of the lung fields, effusions, that is presence of fluid in the pleural cavity, foreign bodies, gastric bubble under the left dome of the diaphragm, great vessels, that is the aortic knuckle, and the hilum of the lung. These are the normal anatomical landmarks which are visible on a chest X-ray. There is another view, that is the lateral view of the chest, in which we can see the lung fields, the heart shadow, the thoracic cavity, and the special features which we can see in a lateral view which are not clearly visible in the posterior anterior view are the retrocardiac and the retrosternal air spaces. The next X-ray is showing a white consolidation or a white patch in the upper part of the right lobe. This white irregular patch is a marked feature of pneumonia. This is caused by lung inflammation, and usually it is irregular in margins. Sometimes it is confined to a single lobe of the lung, or sometimes there is a dispersed white there are dispersed white areas in both the lung fields. Again, you have to match the X-ray findings with the clinical signs and symptoms and the medical history of the patient. In the next slide, you can see on a posterior anterior chest X-ray, there is a rounded body present in the midline, which is marked by an arrow. This is a foreign body either in the trachea or in the esophagus. Usually all metallic objects except aluminium are opaque, and most animal bones and all glass foreign bodies are opaque on a radiograph. However, most plastic and wooden foreign bodies and most fish bones are not opaque and give you a very hard time for diagnosis, and you have to rely on the history alone. This image shows a rounded mass in the lower zone of the left lung. Whenever there is an abnormal area of shadowing, that is increased density or whiteness in the lungs, the diagnosis of infection or cancer should be considered. And in case of cancer, the white density or opacity will be well rounded or well circumscribed. But this is not the case always. You have to correlate with the clinical findings and the clinical signs and symptoms. In this X-ray, you can see the blunting of the left costophrenic angle and formation of a meniscus that is the upper border of the white opacity. The arrow is pointing towards the blunted costophrenic angle. This is a peculiar lesion found in the pleural effusion case due to the presence of fluid in the pleural cavity. The fluid settles in the lower regions. This is a chest X-ray of a pneumothorax case. A large left-sided pneumothorax has occurred from a rupture of a subpleural bleb or due to trauma to the rib cage, pushing the mediastinum to the right side. You can see that the size of the left lung field is larger than the right lung field, and there is absence of bronchovesicular markings on the left lung field, whereas you can see the bronchovesicular markings as normally present in the right lung area. This is due to the presence of large amount of air in the left pleural cavity or in the left mediastinal region. It appears more black as compared to the right side due to the presence of air. This chest X-ray shows typical findings of emphysema. In emphysema, there is hyperinflation of lungs, which is also present in asthma and chronic bronchitis. All of these diseases, asthma, emphysema, and chronic bronchitis, are chronic obstructive pulmonary diseases. And in the chest X-ray, we can see the hyperinflated lungs. The lung fields are more darker, the diaphragm is set low and more flatter. The diaphragm is even set low to the 11th or 12th posterior rib. Heart shadow is compressed because of the hyperinflated lungs. It appears vertical and narrow, and there is presence of air under the cardiac shadow. There is increased AP diameter, anteroposterior diameter of the thoracic cavity, but that we can appreciate more in a lateral chest X-ray view. Chronic bronchitis, again we will see the same findings of hyperinflated lungs, but in this case we see prominent bronchovesicular markings because of the presence of secretions in the airways. Pulmonary tuberculosis, it is a chronic specific lung infection caused by tubercle bacilli, and there are a variety of findings we can found on chest X-rays in a case of pulmonary tuberculosis. The most common findings are presented here. In the first X-ray, the arrows are pointing towards the hilar lymph nodes, the white opacities in the lung hilar regions, showing the enlarged lymph nodes. In the second X-ray, you can see a cavitating lesion in the upper lobe of the left lung, which is caused by the caseating necrotic lesion of the tubercle bacilli, caused by tubercle bacilli. This is a chest X-ray of a case of miliary tuberculosis. You can see in both the lung fields scattered crackles caused by the miliary tuberculosis lesions. There are multiple conditions in which this type of finding is seen on a chest X-ray, like histoplasmosis, sarcoidosis, pneumoconiosis, bronchoalveolar carcinoma, pulmonary cirrhosis, hematogenous metastasis from primary cancers of thyroid, kidney, trophoblast, and some of the sarcomas. And you have to match this chest X-ray with the clinical findings and the medical history of the patient to confirm the diagnosis. In case of miliary tuberculosis, there will be a chronic history of tuberculous infection. Primary lung cancer with hematogenous spread also depict the same finding on a chest X-ray. There are some other findings which are very commonly found on a chest X-ray are cardiomegaly and pulmonary edema. In the first X-ray, you can see enlarged shadow of the heart compressing the lung fields due to heart failure. In the next X-ray, you can see a bad swing pattern due to alveolar edema. In acute cases of pulmonary edema, alveolar edema radiates symmetrically from the hilar regions, giving a bat wing appearance. This was the brief description about abnormal findings on chest X-rays. Hope this will be beneficial for you. If you have any questions, you can leave in comments. I'll definitely try to answer them. Thank you so much.